Hi, my name is Elizabeth Dellin, and I am honored to be asked by our session chairs to present today on palliative care and CF. Why is it so complicated? This is a part of the Complicated Complications session. I have no relationships to disclose. Palliative care in CF, as defined by multiple stakeholders, focuses on reducing physical and emotional symptoms and improving quality of life for people with CF throughout their lives. Palliative care occurs alongside usual treatments and is individualized according to the unique goals, hopes, and values of each person with CF. The key domains of palliative care, kind of for purposes of this presentation, but also in practice, are symptom management, communication, emotional support, and care coordination. Why is palliative care important in CF? I've highlighted a few aspects of that definition that I think illustrate this on the left, and on the right, I have some rationale. So CF is a lifelong progressive condition with unpredictable outcomes for each individual. There's currently no cure for CF. There are high symptom and treatment burdens associated with CF. And there's increasingly complex decision-making as the disease progresses. Importantly, there's also a significant caregiver burden that comes along with CF. When is palliative care appropriate? Again, highlighting here on the left in our definition, really throughout the lifespan of someone in CF. And this figure on the right from an ATS statement on palliative care for people with lung disease illustrates this, I think, nicely. Curative and restorative or restorative disease-directed care in the case of CF is illustrated in the solid line, and on the dotted line is palliative care, which is present from the time of diagnosis, rides alongside restorative care, intensifies at times that the disease is worsening, and at some point, if it becomes apparent that someone isn't going to survive, palliative care really kind of supersedes disease-directed therapies, with hospice being an appropriate approach to therapy, to care near the end of life for many people. But palliative care in CF can be complicated. Why is that? Well, it may be different than in some other conditions. We have talked a lot about this as a group of people interested in palliative care in CF, that we are dealing with a young population overall. It's a lifelong disease. Importantly, there are changing outcomes with therapeutic development, and this is overall very positive, of course. We see improving life expectancy, better quality of life for many people. However, new therapies aren't available to everyone. Not everyone responds. Some people are at a stage of their illness where even the most amazing new therapies maybe don't confer quite as much benefit as they do to others. So it actually adds even more to the heterogeneity piece, I think, with CF. Additionally, lung transplant as an option for some people with advanced CF lung disease can complicate this sort of issue of palliative care and when and how to incorporate it. There are also common barriers to palliative care generally that apply to CF. So there's an association of palliative care with end of life, and that's really a societal thing that's complicated for many people. There's discomfort among healthcare providers, people living with illness, and caregivers. And I don't just mean discomfort with palliative care. I mean discomfort with the fact that this is a progressive condition that doesn't have a cure, and that's unfair and it's hard. Additionally, lack of training in palliative care principles and practice for CF care teams and other kind of primary clinicians can be an issue, as can access to specialty palliative care. So we're going to talk through some of these complicated issues in palliative care using a case to illustrate some of the things that we run into, really from the perspectives of all of the different stakeholders, so people with CF, caregivers, and the CF care team. So Jane is 17. She is homozygous for F508del. She has had advanced lung disease really since very early in life, unfortunately, and has quite significant malnutrition. She's had a G-tube and really active management with our CF dietitian and GI consultants. She has unfortunately, for whatever reason, had poor response to 2 CFTR modulators, and Jane is pre-Trikafta, so perhaps she might have had more benefit from that, but unfortunately, it was not an option for her. And ultimately, she is referred for consideration of lung transplantation. So as I talk about her case, I'm really thinking about a timeline of her illness here, and some of the illustrations will kind of come in at different time points for her. But in general, she was referred for lung transplant at a time when she was having progressive symptoms and faced that difficult decision, weighing the benefits and the burdens of lung transplant. She got sicker, unfortunately, after being listed, and was admitted to the intensive care unit, where she experienced quite profound worsening of pain and dyspnea, and really faced not surviving to that goal of transplant, as many people do. At this time, she was scared and was worried, and reconsidered that goal of lung transplant. So was truly facing life and death decisions, and also difficult communication, really complicated conversations with her family, with her care teams, with everybody who had been a part of her decision-making and her support. So we're going to illustrate this, like I said, kind of from the perspectives of different people. So I'm going to talk first about some of the healthcare provider concerns that arose along the way in Jane's course. These are real life examples. I think probably many of you can relate to these with lots of people that you've cared for over the years. So the first is, we're not there yet. So the scenario here is that Jane's CF social worker suggests a palliative care consult for symptom management and additional support around the time that she's referred for a lung transplant evaluation. Now, I would agree that it was kind of late at that point, but that would be a really good time to think about it. Jane's CF physician is reluctant, though, because of course now we're embarking on a whole new thing, and we're really talking about survival. We're not talking about end of life. So that's our perception, right, is that palliative care is only for people who are dying. And of course, Jane may be dying, but that's not what we're focusing on right now. Her physician was also really worried about taking away hope, thinking, gosh, if we're talking about something that we're hoping will extend her life, doesn't bringing in, some of the sort of aspects of palliative care maybe imply that she shouldn't be hopeful for that. The realities in this case are that palliative care, as we mentioned before, is really appropriate throughout the lifespan for all the reasons that we mentioned. And certainly this is a time when palliative care consultation could be very helpful. And really, truly, hope is not ours to take away. I think that's something that we spend a lot of time as clinicians worrying about. I think caregivers worry about this. I think the individual person with CF gets to hope for what they're hoping for. And really our job is to tease out what the biggest hopes are and maybe what the littler ones are that come along the way if we can't have the outcome that we want. So some solutions along those lines. First of all, let's solidify our understanding of palliative care. What is palliative care? Who's it for? What is it not? And let's get more comfortable with that so that we can really thoughtfully introduce palliative care to people who might benefit from it. Let's screen for needs and assess them. And sometimes our CF care teams can really address a lot of palliative care needs, but sometimes a specialist could be helpful. And then coordinate care. So if we're going to be involving other consultants, we already have a CF team and maybe a transplant team involved. Let's make sure that we're also coordinating with the palliative care team and making sure that we're thinking about role delineation, thinking about who needs to be addressing what aspects of care and how we can partner. Another common health provider concern is just say no to opioids. So I'll comment first of all that this is often a concern of patients and caregivers as well, because of course there's a lot about opioids that is worrisome, but I'm going to illustrate from the healthcare provider perspective. So Jane has worsening chest pain and dyspnea, and the palliative care team is indeed consulted. And after working with the primary team, and in this case the PICU team because she was in the ICU, on optimizing pharmacologic interventions that didn't involve opioids, and of course, non-pharmacologic interventions, recommended a trial of low-dose opioids. The perceptions here from the part of the team that says, no, I don't think so, is that opioids are dangerous in CF and shouldn't be prescribed. Palliative care specialists are also perceived as just prescribing opioids for everyone sometimes, and that can complicate this situation. The realities, though, are that some people actually do need opioids to effectively control pain and or dyspnea and allow them to function and participate in therapies optimally. It can be very important to quality of life. Another reality is that it truly is possible to prescribe opioids safely. Additionally, remember that palliative care specialists also want to avoid opioids except when clearly indicated. I think it's just a tool that is sometimes necessary and can be very effective. Some solutions to this really are just safe prescribing. We can all reinforce our own education, and we can collaborate with others to think about dosing, to think about route, to think about monitoring, to proactively manage side effects, and of course to have a de-prescribing plan if somebody's condition is improving, or say Jane is transplanted, how are we going to work toward getting her off of opioids? That should always be a part of the plan up front and communicated clearly to the patient. So we've thought a little bit about healthcare providers. Let's talk about Jane and some common patient concerns. So one of them I would just broadly call saving face. So the scenario is that Jane is in the ICU and she's really struggling physically and emotionally. She's no longer sure about transplant, but she's afraid to tell her CF and transplant teams because after all, they've really helped her to make this hard decision and supported her along the way. Perceptions on Jane's part are that the path to transplant is chosen and she'll be disappointing people, her team, her family, and others if she doesn't do this. Also that healthcare providers might not support a change in plans, again, because they've worked so hard to get to this point. The realities, though, are that for anybody who's facing a really serious illness, perceptions of benefits versus burdens of any treatment can change and often do. And truly, the CF and transplant teams should be a safe place to voice concerns. I would imagine we all endeavor to be a safe place for our patients, but sometimes we have to let them know that. So some solutions are to start conversations earlier. What would happen if you got so sick that you started to second guess? Let's think about what we would do in that scenario. Explore goals, hopes, and fears along the way. And also preparing patients and families for the fact that wishes may change, and reassure them that you'll be there to support them. We might not agree, but we can still support each other. Another concern that is common to patients, and certainly was one of Jane's concerns around palliative care, was speaking fears into reality. So here the scenario is that Jane decides to stay on the transplant list, but her health continues to decline. She tells her mom that she is not really able anymore to hear bad news. She just wants mom to have the conversations outside of the room. Jane's perception is a common one, that if we talk about scary things, then they'll happen. The realities, though, are that unfortunately the outcomes we all hope against may unfortunately happen, and it really doesn't have anything to do with whether we've named them or not. And in fact, if we don't share important information, we really deny people the opportunity to plan for things that they can plan for and to make fully informed decisions. Some suggested solutions here are just try really hard to meet people where they are. So acknowledge that it's hard for her to hear these things, but remind them that it's your job to be honest and to share factual information so that they can make good decisions with your support. And really remind and reassure patients and caregivers that we're hoping along with them. So if we're bringing up something that's hard or scary, it doesn't mean that we're hoping for that or we're anticipating that. We're still hoping for the things that they're hoping for. We just are obligated to share information. And finally, I wanted to address a few caregiver concerns. So these, of course, caregivers in CF can be parents or other adults in the case of children. For adults with CF, it may still be parents, it may be partners or spouses, but caregivers are often very involved in the care of people with CF, thankfully, throughout the lifespan. So some caregiver concerns that are common are what happens when there are limitations on interventions. So in Jane's case, after a really tough night in the ICU, the team tells Jane's mother that they worry she's nearing end of life. She may not survive intubation or CPR if she declines further. This conversation is held just with mother as per Jane's request, but it's hard to hear. Jane's mother starts worrying because she has heard from other people that DNR sometimes seems to mean do not treat. If we say that we wouldn't want resuscitation to be attempted, then suddenly everybody treats you differently and maybe aren't as focused on survival and are more focused just on comfort. And that's really not what they're asking for at this point. Especially this can be the case when one has already shared some reluctance to continue. In Jane's case, waiting for transplant, and her mother does not want these fears to be realized. The reality we all know is that DNR means do not attempt resuscitation, and that's literally all it means. Everything else is the same unless otherwise defined. I think, though, that we often do practice a little bit differently, or we speak to people a little bit differently when those decisions are made. And so that's something that we need to be mindful of. So some solutions are to explore goals, hopes, and fears, readdressing wishes as a person's condition changes. That's just reiterating that. To make recommendations for things that feel medically reasonable based on a person's goals and explain why we're making them. Many people describe during a serious illness riding a roller coaster, and that can be intensified in the ICU, where maybe something that we say we would never recommend is the very thing we're recommending days later or hours later. And this can be very startling to people. And so really helping people understand why we are making recommendations now that maybe we didn't make in the past can be critical. And I would also say it's just so important to always focus on what we are doing, what we will still do, regardless of a person's choices around resuscitative measures. This is something that I think we have to just be very mindful of. We always want to be talking about the care we are providing. We will always provide high quality care regardless of what our ultimate goals are. And finally, another caregiver concern is I don't want her to stop fighting. So Jane's mother is told that Jane might not survive to transplant and that transitioning to a comfort care plan is an option, and was encouraged to involve Jane in this conversation. And Jane looked to her mother to find out what she should do. And her mother said, I just don't want you to stop. I don't want you to stop fighting. This is hard. And the perception here is that CF is a battle that a person can win or lose. Conceding, maybe not a great choice of words, but just if we don't keep fighting, we will die. The reality here is that it may feel like one every day, every minute for some people, but it's something that people have to live with every day, and the pressure to fight may be overwhelming. So there's actually really interesting literature on fight language, especially in oncology, and this is something that many of us may feel differently about, but I bring it up because I think it is important to consider. So some solutions here are really to explore whether fight language fits the narrative of the person with CF. If they use those words, understand what they mean, and then go ahead and have that conversation using their language as they define what fight means to them. But applying it to someone can be very difficult for them. Really, truly, some caregivers might feel that way, even if the person living with CF doesn't. And we want to give them space to talk about their worries and offer suggestions if there are differences of opinion for how to support that person with CF. So those are my examples, and there are many, many more that I could give, and many more that you probably have all experienced. But needless to say, palliative care in CF can be complicated, but it doesn't always have to be. And really the big take-home message here is that thoughtful communication goes a long way. It's actually critical. Thoughtful communication around any issue, even the simplest of issues, builds trust. If that's our baseline, then as people struggle more and face harder decisions and get sicker, we've established trust, and we know that we can communicate openly. Thoughtful communication can dispel myths and misunderstanding, which are also really important as we move along in the course of illness. And importantly, thoughtful communication really places the person with CF at the center, which is, I think, where we all know that they belong, but we want to make sure that we're always making people feel that we're on their team and we're there for them. I'm just going to throw up here a couple of palliative care resources. There are many, many, many that are not specific to CF. Many of those are proprietary, so I'll let you search for those on Google, but lots of great information out there. CF-specific resources, the CF Foundation Patient Registry Resources section and Resources Library, which require password access, but have some really nice information that is, a work in progress. We're still building that. Also, the UK Trust Palliative Care Resources at the website here has some wonderful resources that you can access. I will also mention that palliative care, models of palliative care in CF guideline is in press, and once that's published, we will have some additional resources for teams and for our patients and caregivers available. Thank you very much.
Hello, my name is Dr. Rose Franco. I'm a professor of pulmonary and critical care medicine at the Medical College of Wisconsin. I'm also the associate director of the Adult CF Center here in Milwaukee, Wisconsin. Thank you for joining us today to talk about complicated complications. My talk is going to be on non-invasive ventilation and cystic fibrosis, do's and don'ts. First of all, I have no disclosures other than to thank the Cystic Fibrosis Foundation for providing us with a pilot grant to develop integration of personal activity tracking devices with the PORT-CF data. In order to understand non-invasive ventilation and cystic fibrosis, we have to start at the beginning. As far back as 1992, there was evidence that non-invasive ventilation can be beneficial with advanced lung disease and cystic fibrosis. In this publication, 4 adults were followed for 18 months, and all reported improved energy and sleep. They measured objective improvement in hypercapnia as well as improved muscle strength. The authors of this article concluded that for end-stage cystic fibrosis-related hypercapnic respiratory failure, that non-invasive ventilation could be advantageous for those awaiting lung transplantation. Additional publications in 1991 and 1996 also discussed using non-invasive ventilation as a bridge to transplant. Early studies, such as this one published in 1998, also demonstrated improved oxygenation and hypercapnia. This particular study was of 8 adult patients with significant lung disease. In order to understand how non-invasive ventilation helps, we have to go back to the physiology in both normal lungs and in patients with advanced disease in cystic fibrosis to understand how it improves gas exchange and decreases work of breathing. Here we have a normal set of lungs. When we look at the way that air flows in and out, we see that in order to get air into the lungs, there's a significant change in pressures in the chest as the diaphragm moves down and the chest wall muscles move out. Air rushes in because of a big pressure swing that is more noticeable when we measure the intrapleural pressures. This results in an increase in volume in the chest, followed by exhalation where we have a decrease in volume in the chest. When we look at the patient with cystic fibrosis, we have to recognize that over time there's damage to the airways that leads to cystic changes with the bronchi becoming damaged, as well as scarring that you can see in the upper right-hand corner, the fibrosis that totally destroys the upper lobe or significantly destroys the lobes and results in a component of fibrosis as well as obstruction. Here we have an example of the patient with cystic fibrosis who has mucus plugging and destroyed airways. What is not depicted is the fact that the diaphragm is typically more displaced downward and that the chest wall is also displaced outward due to hyperinflation as part of the CF disease as it becomes more progressive. As a result, there's much wider pressure swings. When we look at the change in intrapleural pressures, there are as much as a change of 30 millimeters of mercury, which goes off the charts here, so I just left the diagram as is. This results in a tidal volume, but a significantly reduced tidal volume compared to someone without lung disease. So when we look at the output, there's basically more effort with less tidal volume and more prolonged expiratory phase. This translates into more work. One way of thinking of work of breathing is to think of it as one would cogs that are interlocking. In a normal person, the biggest effort is coming when we inhale, And we have to overcome the elastic forces of the lung to get the lung to expand. And we do very little to get the air out. In a patient with CF, that effort to breathe out becomes a significant component of extra work. Here's an example of the work in action. When we measure the interpleural pressures, one way to measure them is to use an esophageal manometer. Here we have on the left a normal, esophageal pressure manometer in a patient with advanced lung disease. You can see these wide swings in pressure that are occurring in the fast respiratory rate. When the patient's put on BiPAP, however, we see there's a significant decrease in the amount of pleural pressure swings, as well as a decrease in the ventilatory effort and increase in tidal volumes. So you have decreased effort and improved ventilation as a result of BiPAP. Why does BiPAP help? One of the reasons is when we have floppy airways, such as we have in cystic fibrosis, we develop air trapping. As depicted in this cartoon, we can see that in a patient with lung disease, you may have as much as 10 of pressure trapped behind a collapsed airway, as seen in the upper left-hand cartoon. Because of that, there's a lot higher pressure swing needed to get air past the obstruction, and that's where the extra work comes in. Trying to overcome first the intrinsic PEEP in order to get the air in can be part of the extra work of breathing. And adding positive pressure to the airway, as seen in the cartoon on the right, helps to overcome that extra work to inhale and also reduces the work of breathing. In the study published in 2004 in the European Respiratory Journal, we see that the work of breathing for just 15 minutes in an advanced CF patient can be significantly improved with non-invasive ventilation. In this study, there were 5 CF patients who were studied. And we can see, based on the last line that I have outlined in blue, that the work of breathing when they were breathing spontaneously was 1.64 joules per liter. And when they were placed on non-invasive ventilation, it was less than half that for the work to breathe, which was almost comparable to when the patients were put on an invasive ventilation or through an ET tube. When should we start to consider non-invasive support with cystic fibrosis? Well, any patient with advanced lung disease in CF should be considered. Signs of excess work of breathing would be weight loss, increased respiratory rate, low saturations, and the symptoms may be shortness of breath, or even just cutting back on things they like to do, decreased interactions, decreased outings, and of course, poor sleep. Now, the big question is, what type of ventilator should we be talking about? Now, early on, the only ventilators available were volume-targeted ventilation, and that's characterized by delivery of a fixed predetermined tidal volume. The main advantage of this type of ventilation is it's guaranteeing a tidal volume and a minute ventilation. It's best for neuromuscular diseases, but in the initial evaluations of CF, we do have evidence that it did help, and this was published in 1991 and 1992 in the European Respiratory Journal. Now, pressure support is a pressure-targeted mode, and that is more comfortable because the patient controls the breath rate, the inspiratory duration, and the tidal volume. And so you have better synchrony between the machine and the patient. Now, when we talk about pressure support modes that are most common, the tried and true is BiPAP, but more recently, an advanced type of BiPAP has been developed called AVAPs. Bilevel ventilation, or BiPAP, you set the inspiratory pressure and the expiratory pressure that stabilizes the upper airway and the lower airways. So the PEEP helps to resolve the upper airway obstruction, as well as resolve the work to overcome the intrinsic PEEP. And we do have evidence published in various journals that use in CF does help reduce work of breathing and help support their ventilation. AVAPs, or proportional assist ventilation, is a pressure-supported targeted tidal volume and targeted minute ventilation. So there's more alarms, more forced breathing, but it still allows some flexibility to the patient. And instead of forcing a breath, it more gives a physiologic nudge to get the breath the size that we need and help bring up the rate of breathing to a point where there's improved gas exchange. Now, this type of ventilation has been studied in cystic fibrosis more recently in 2014, showing that it is effective in helping to support ventilation and improve gas exchange. The newest kid on the block is a mode of ventilation called AVAPS AE. This combines the best of auto CPAP, which we use typically for sleep apnea, and AVAPS, which we just talked about. There's been no studies in CF, but in a study that's still in press in the European Respiratory Journal, they studied it in advanced COPD and found with these 10 subjects that it significantly decreased the effort needed. As we can see in the table, the EMG percent effort decreased significantly on the AVAPS AE, which is in the column labeled EPAP. As a result of decreased work of breathing, these patients would have better support than if they were on a standard BiPAP mode. I'm not going to go into details about what the right settings are. Most of these machines have standard industry recommendations, but typically you're targeting 6 to 8 cc's per kilo for your target tidal volume if you're using the AVAPS mode. And for BiPAP, we typically start with a EPAP of 5 and work our way up to get the most comfortable breathing, and an IPAP of at least 10, if not higher, to try to get a good sized breath. With AVAPS AE, again, some additional suggestions are here for patients with COPD, which is in the the right-hand column. You can see that they typically want you to start with a range with the EPAP. Keep in mind that intrinsic PEEP will force the EPAP setting up in these patients with advanced lung disease. Now, the requirements from Medicare for non-invasive ventilation are very prescriptive. You have to have the diagnosis of chronic respiratory failure and use the ICD-10 code is labeled here, and that it has to be due to restrictive thoracic disease, not COPD. The PCO2 for this criteria needs to be greater than 46 on a blood gas that is done when in a stable state, in other words, with a normal pH. That there needs to be evidence of desaturation on the patient's usual oxygen flow or room air. The recording has to be at least 120 minutes of sleep, and you only have to demonstrate 5 minutes of desaturation time. And then on the prescription and in the note, you have to put that COPD does not contribute significantly to limitations. And of course, there needs to be a face-to-face documentation of need prior to writing this prescription. Here's an example of the statement we use in our clinic. After a face-to-face interview with the patient and reviewed a chart, I've concluded my patient suffers from chronic respiratory failure as a result of restrictive thoracic disease. COPD does not contribute significantly to their limitation. This patient requires non-invasive ventilation for the home to reduce the work of breathing and improve pulmonary status with mouthpiece ventilation during the day and mask ventilation at night. Bi-level is inadequate to handle the variability of effort as well as rapid progressive respiratory failure that is common with this condition. Patients require alarms, battery backup, and portability, which isn't possible with a simple BiPAP. This device is used effectively to treat and decrease the work of breathing and will improve their pulmonary status. If the patient doesn't have this device, they're at risk for repeated admissions, respiratory failure requiring invasive ventilation, or possible death. One of the questions I often field is, do I need a sleep study to be able to get my patient on this device? The role of the sleep lab for this type of indication is variable. Most sleep labs are not equipped to truly do a titration of non-invasive ventilation. What's really important is to have an experienced respiratory therapist or sleep technologist who is versed in non-invasive ventilation. Ideally, you'd want to be able to measure end-tidal CO2 in oximetry, and if you're lucky enough to have a lab that has esophageal pressure manometry or has diaphragmatic EMG, this would be a plus in helping to guide the titration. Setting up the non-invasive ventilation, as I said in the earlier slides, requires some standard settings with a breathing pattern, gas exchange, ideal body weight, and comfort in the clinic, or to use a physiologic titration through a sleep study. But once the patient's set up, remember, you're not done. You're just starting, and you need to adjust settings and practice. Adjust and practice. So seeing the patient weekly is not a bad idea until you come up with the right settings that are most comfortable for the patient, and then you monitor their progress. Yes, we're on the verge. We're on the verge of really improving the health of our patients with cystic fibrosis. And today our talk is on patients who've already suffered significant lung damage, and we need to stabilize their status and help work them toward transplant. But in the future, highly effective therapy for cystic fibrosis may lead to a transition from skinny mighty mite to plump wrestler, and they may need CPAP more than they need BiPAP. Only time will tell. Thank you for your time.
Good afternoon. My name is Adam Kimple. I'm an assistant professor at the University of North Carolina in Chapel Hill in the Department of Otolaryngology, Head and Neck Surgery, specifically in the Division of Rhinology and Skull Base Surgery. Basically, what that means is I'm interested in sinuses, mucus, and how it moves within the sinuses and nasal cavities. There are no financial relationships to disclose related to this presentation. I'll try to hit these 6 bullet points in the next 10 to 15 minutes. We'll start with why we have sinuses. We'll talk about where the sinuses are located. Why do patients with cystic fibrosis have sinus disease? What are the symptoms of sinus disease in a typical patient as well as in cystic fibrosis? What is sinus surgery? And we'll go into a little detail about some of the extended procedures that a lot of patients with cystic fibrosis eventually undergo. And we'll talk about modulators and sinus disease. Why do we have sinuses? The sinuses have multiple roles, one of the prominent ones being to absorb shock. The sinuses can be thought of the crumple zone of the face and head and serve to protect the eyeball and the brain during trauma. The sinuses also lighten the skull, allowing us to carry our head upright. The sinuses and nasal cavity in general humidify and warm air before it gets to the lung to optimize it for gas exchange. The sinuses serve a defense role, protecting the lower airways by filtering out larger particles, bacteria, and some viruses. And the sinuses and nasal cavity in general are the location that detects odors. We have 4 sets of paired sinuses. In the forehead, we have the frontal sinus shown in blue. Immediately below this is the ethmoid sinuses shown in green. Unlike the frontal sinuses, the ethmoid sinuses are composed of many, many partitions, or a small honeycomb network is what I tell my patients. Below the ethmoid and kind of to the right and left, we have the maxillary sinus or the cheek sinus. This sits above the roof of your mouth and below the eyeball. The furthest sinus back, again between the eyes, is the sphenoid sinus shown in red here. The cystic fibrosis transmembrane receptor is not only expressed in the lungs and intestine and the pancreas and reproductive tract like we've seen many talks about at this conference, but it's also expressed in the nose and sinonasal cavity. Just like in the lungs where we end up with more viscous mucus or thick mucus because of the defective CFTR, the same thing happens in the nose. And in the nose and sinuses, this thicker trapped mucus serves as a reservoir for bacterial overgrowth. It's warm, moist, and dark within the sinuses. This leads to bacteria, which create inflammation, which feed into more mucosal thickening, and that traps more mucus. So it's really a vicious cycle, triggered by the increased viscosity of the mucus. Traditional symptoms of a sinus infection are purulent rhinorrhea, as depicted here on my son, facial pain and pressure, and nasal obstruction. However, in patients with cystic fibrosis, 2 of these 3 cardinal symptoms are frequently not observed. In particular, the facial pain and pressure is frequently not present, and the nasal obstruction is often not appreciated. Part of this is thought to be because people have had this present their entire life, and so they just don't really notice it. Frequently, in my patients with cystic fibrosis, I also notice a lot of them have headaches that are related to sinus disease. In other patients, I'll often tell them that there's no way that their sinuses are causing their daily headaches, but in cystic fibrosis, I think all bets are off. So what is sinus surgery? Sinus surgery is called functional endoscopic sinus surgery. This is performed under general anesthesia, meaning that you have a breathing tube placed. And the reason for that is to protect the airway and the lungs from any bleeding that happens during the sinus surgery. And also make sure you're still. Most of the time in the United States, it's done with image guidance, which I tell my patients is like a GPS system for your sinuses. And that's one of the reasons the CT scan is important, is because we use the CT scan to kind of map your sinuses during the surgery. The goal of sinus surgery is to remove diseased tissue, polyps, infection, and create an open floor plan. As I mentioned when I was talking about the ethmoid sinuses, the sinuses are frequently kind of have lots of small partitions and walls and individual rooms. Each one has its own drain hole, but one of the goals of surgery is to basically take all those rooms apart and create a large open floor plan between your eyes to allow for better irrigations and better drainage. The goal of surgery is to improve quality of life, allow better delivery of topical medicines, and decrease bacterial seeding. Here's an example of a sinus surgery in a patient with nasal polyps, and you can see we're removing the polyps. They're jiggling back and forth, and this is pretty satisfying. And then after the polyps are removed, then we'll start to actually open up the sinuses, kind of transitioning from that 80s floor plan with lots of small rooms into a nice modern floor plan with very few walls. Really, the structural walls are what we leave intact. In addition to sinus surgery or functional endoscopic sinus surgery, patients will sometimes undergo a septoplasty. A septoplasty is straightening the septum. The septum is the part of your nose that separates the right nostril from the left, shown here in red. The two little T's represent the turbinates, which are kind of baffles that everybody has in their nose and frequently get identified as polyps if you can't get good visualization with an endoscope in the nasal cavity. In patients with a deviated septum, frequently they'll have increased obstruction on the side where the septum goes, on the right side over here. On the left side, there might be better airflow, but this inhibits the ability to do sinus surgery because you can't get good access. During a septoplasty, a small incision is made inside the nose. The cartilage that's crooked is removed, but all the supporting cartilage is left in place, and the septum, or the wallpaper, the mucosa of the septum, is put back down. The primary goal of this is to allow for access during surgery and allow access after surgery for debridements. It'll also help improve nasal breathing. After sinus surgery, I typically tell my patients that they're going to feel like they have a terrible sinus infection. They're going to have bloody drainage for about the first couple days. There's frequently a temporary drop in lung function. And often I'll have them on a course of antibiotics for somewhere between 14 and 21 days, depending on how infected their sinuses were. I instruct my patients to rinse their nose with saline using a Neilmed or similar type of low pressure, high volume lavage 2 to 5 times daily, because this really helps clear out some of the crusty boogers that are building up after surgery. And then most patients come back within 1 to 2 weeks for a debridement, which is when we kind of go into their nose and surgically pick out boogers in clinic. Generally, you can't use CPAP or BiPAP right after surgery, and the reason for that is twofold. One is because there's a small fear of pushing some of that air into the eye, which can be painful. And the other reason is because it really dries out the nose and can make healing much harder. On patients who are on nasal cannula or oxygen continuously, healing is much more difficult as their nose is so dry from that extra air, even with humidity. After a septoplasty, I frequently tell my patients that it's going to feel like I punched them in the nose. It adds a considerable amount of pain compared to just sinus surgery alone. Frequently, because of the way we get to the cartilage, the front teeth are temporarily numb, and often there's some increased congestion initially as things settle down and start to heal. Nasal packing in general is a thing of the past. In the 80s, 90s, and early 2000s, gauze packing was frequently used, and it'd be kind of these yards and yards of gauze put into the nose right after surgery to decrease bleeding. Patients who've had this done report it was one of the more painful experiences of their life. And in patients that I've seen who've had this, it creates a lot of scarring. In general, there aren't a lot of practitioners across the country who use formal gauze packing anymore. Today, different providers will use finger cots, which are essentially like a tampon and a rubber glove that's placed in the nasal cavity after surgery. And this helps with the first debridement and helps decrease the risk of bleeding, but it is uncomfortable. Some providers will use dissolvable packing, which will either slowly irrigate or dissolve with the rinses that you're doing. And some providers use steroid-eluting stents, which can help hold open sinuses and deposit steroids in that tissue locally. After surgery, the goal is to be able to see all the sinuses nice and open, as shown here. That's the sphenoid sinus, the furthest back there. This is the ethmoid cavity. And in the very front, we'll see the frontal sinus there. The mucosa is nice and pink. There's not a lot of green crust. There's not a lot of mucus accumulating, and that's essentially our goal. Patients with cystic fibrosis in particular, and some patients with other recalcitrant sinus disease might have some extended sinus surgery. This is sometimes described to the patient as medial maxillectomies or megaantrostomies. And you can see here a patient with cystic fibrosis, because you still don't have normal mucosary clearance, frequently has pooling of mucus within the cheek sinuses. All this gray here above the teeth, above the floor of the maxillary sinus, is essentially trapped mucus that doesn't come out. And you can see that on the right and the left. The goal of a medial maxillectomy is to remove this component, the medial maxillary wall, to some degree, so that when you do rinses and through natural gravity, mucus can drain out of the nose better and accumulate less. In addition to this, some surgeons will talk about a frontal drill out or a draft 3. And the goal of this is similar to the medial maxillectomy, is to really widely open up the frontal sinus. Typically, the frontal sinus opening is narrowed by the septum, which goes all the way up to the skull base, or basically to the brain. And in a frontal drill out or a draft 3, part of the superior septum is removed, allowing bilateral access to the frontal sinus. And here you can see a post-operative draft 3. This is the middle turbinate, the septum, the middle turbinate, and you can see you can access the frontal sinus from both sides. One of the benefits of this surgery is that when you're doing the irrigations, it can come around the septum and really clean out that frontal sinus better than it probably can if you haven't had this type of aggressive frontal surgery. Modulators are really changing the way we see patients with sinus disease and cystic fibrosis. Here's the 4 on the market currently, and there's not a lot in the literature right now about what modulators do to sinus disease. There's a couple studies, this by Sheikh et al. In 2015, had 12 patients in their study and looked at CT scans on patients on ivacaftor and at least one copy of a G551D. And in their CT scans, they saw considerable improvement after the start of modulator therapy, as depicted here in one of their representative patients. And there are 12 patients overall. Most of the patients had an improvement on their CT scans from severe to mild, moderate to mild, severe to moderate, with the only patient who didn't have an improvement documented had normal sinuses prior to initiating the modulator. There was one additional study with ivacaftor, and this was a sub-study or a analysis of the sinonasal outcome test from the GOAL study. This had 153 patients, again using ivacaftor, and again having all the patients having at least one copy of the G551D variant. The outcome looked at here was not CT scans, but was a sinonasal outcome test. In sinus disease, frequently the most important indicator of whether patients are doing better is their quality of life, and that's measured by essentially a SNOT 20, a SNOT 22, or the RSDI are kind of the 3 main tools that are used. This study was part of a larger observational study, and what you can see here is that after starting modulator therapy on ivacaftor, at about 1 month, patients had improved quality of life. One of the problems with quality of life studies in patients with cystic fibrosis is these instruments were developed for patients with run-of-the-mill chronic rhinosinusitis and not CF specifically. And so patients with cystic fibrosis tend to report nearly normal sinonasal quality of life. And again, I think as I'd mentioned before, a lot of that's because their nose has never known any different. They've had sinus disease their entire life, whether they've known it or not. And so I think it's actually remarkable that we see a small improvement in sinonasal quality of life in a group of patients who had a nearly normal quality of life to begin with. And I think it's provides some optimism for the future of modulators and sinus disease. There's been one published study looking at triple therapy, tricatheter or ITE, and this had 43 patients out of Columbia with Dimango et al. And they were looking at a different sinonasal outcomes test, the S22, and they looked at 0 and 3 months after initiating therapy, and they saw improvement in the overall sinonasal quality of life, as well as different subdomains with it shown here, as well as the CFQR respiratory domain. I'm involved in another study with University of North Carolina in Pittsburgh, where we're looking at triple therapy. We have 33 patients enrolled, and we're just starting our 6-month follow-ups. And we're looking at SNOT-22s, nasal endoscopy, T scans, olfaction, and microbiome. And we've just started our 6 months follow-up, and we'll look forward to presenting this data at the next North America CF Foundation conference. We have 2 posters on the preliminary data that you can view at your leisure by Stapleton and Kimple. Here's some of our initial data from that study, looking at the first SNOT-22 scores, and you can see a pretty drastic improvement as early as 7 days after initiation that improves to a month and trends down up to 180 days. And so we look forward to kind of really getting into this data once we have our 6-month visits following up. Thank you very much for your time. I hope you found this informative. And if you have any questions, please feel free to reach out and contact me. Have a great day and enjoy your virtual conference.
Hi, I'm Dr. Michael Rispano. I'm one of the pulmonary hypertension doctors at the University of Pittsburgh Medical Center. I'm the director of the Advanced Cardiopulmonary Exercise Testing Program and the head of the CLC Pulmonary Hypertension Clinic. These are my disclosures, mainly related to grant and study support for clinical trials. But my main disclosure is I'm not a cystic fibrosis doctor. Rather, I'm a pulmonary hypertension doctor that mainly deals with patients' invasive and exercise hemodynamics. I spend quite a bit of time in the cath lab performing right heart caths. So we're going to discuss a good amount of hemodynamics during this presentation. The outline for the presentation, we're going to talk about the workup of pulmonary hypertension briefly, hemodynamic definitions of pulmonary hypertension, prevalence of PH and cystic fibrosis, mortality of PH and cystic fibrosis, exercise hemodynamic predictors of outcomes, and treatment of pulmonary hypertension. This is the updated clinical classification of pulmonary hypertension. When most people think about pulmonary hypertension, they think about pulmonary arterial hypertension, in particular idiopathic pulmonary arterial hypertension. But what we're going to discuss is group 3 pulmonary hypertension, which are patients who have chronic common mechanistic etiologies related to lung disease and/or hypoxia, in particular cystic fibrosis. Since 1973, there have been updates on scientific advances, future needs in the field of pulmonary hypertension, utilizing multiple task force groups. The most recent update was the 6th World Symposium on Pulmonary Hypertension that occurred in 2018 in Nice, France. And they discussed pulmonary hypertension and chronic lung disease and hypoxia. There was limited information that was that referred to cystic fibrosis in this write-up, and both sentences I've copied, and this is literally all the information that shows up, and they're very similar. So it shows that in the past 5 years, there haven't been a lot of updates in regards to cystic fibrosis and PH. And as a matter of fact, in 2013, cystic fibrosis and pulmonary hypertension was not mentioned at all. In terms of the workup of patients who have cystic fibrosis that you may suspect pulmonary hypertension, there's usually some clinical, functional, or imaging results that may suggest concomitant pulmonary hypertension that needs to be either supported with an echocardiogram and ultimately confirmed if there's high enough suspicion with right heart catheterization. From there, patients can be stratified into either two groups if their pulmonary artery pressures are elevated, either group 1 PH, which are patients who may have limited chronic lung disease, not a major impact on their spirometry, minimal parenchymal CT changes. Those patients would be considered to have group 1 pulmonary arterial hypertension, or patients who fall into a different category of severe chronic lung disease, where there's a significant impact on spirometry, extensive parenchymal changes, and they would be considered to have group 3 pulmonary hypertension. Those patients should be referred to expert PH or lung disease center. And those patients will be further classified as either having mild to moderate pulmonary hypertension, where most patients with cystic fibrosis, if they do have an elevation in PA pressures, would probably fall into this category, who may not require pulmonary hypertension therapy, or there's a group that may fall into severe pulmonary hypertension that may need individualized care. Either way, both of these groups, if eligible, can be referred to registries, randomized controlled trials, or even consider exercise training, as that's been shown to be beneficial in patients with obstructive lung disease, in particular emphysema. Now, often when evaluating for pulmonary hypertension, patients' first stop is having an echocardiogram, because you want to know what the RV function is, but you also want to know what the RV systolic pressure is. Patients who have CF or underlying lung disease often have studies that come back as being read as it's a difficult study. And that's mainly due to lung disease being in the way. And this is an example of a patient who had cystic fibrosis, pre-transplant, post-transplant echoes. This is a measure of the tricuspid regurgitant jet velocity. And as you can see, pre-transplant with diseased lung in the way, you really can't see the TR jet very well. However, once the lungs were transplanted, that diseased lung isn't in the way, and you can see much better TR jets. So the moral of the story here is that if you get an echo on a patient that you're suspecting pulmonary hypertension, and the report is that it was a difficult study, it may be worth looking at the images and determining if this is a patient that needs to go on to a right heart cath, regardless of what the data shows, because it may not actually be accurate. When do you refer a patient for right heart cath in cystic fibrosis patients? The right heart cath should be considered if it's going to change your management. Either you're going to refer a patient for transplant, they may be included in a clinical trial, you may be able to determine if there's left heart dysfunction that could be treated differently than those who may have pulmonary vascular disease, or if you want to have a compassionate use for therapy using pulmonary vasodilators. Right heart cath may also be considered if there's a patient who has clinical worsening, or if their disease is disproportionate to what you see in terms of their exercise limitation and or gas exchange, or if there's an accurate prognostic assessment that's deemed sufficiently important. The definition of pulmonary hypertension has changed more recently since 2018. The most recent definition has lowered the mean PA pressure to about 20 millimeters mercury at rest, primarily due to clinical information and data that showed a normal mean PA pressure at rest is about 14 millimeters of mercury, plus or minus 3.3 millimeters of mercury. And two standard deviations outside of that would bring you to 20 millimeters of mercury, or what would be considered the upper limit of normal. Pulmonary arterial hypertension definition has also changed, where that mean PA pressure is lower. And this describes patients who have underlying pulmonary vascular disease, where a mean PA pressure alone of 20 could be applied to patients who have either left or right heart disease. This is specific to pulmonary vascular disease. As the mean PA pressure is elevated, the pulmonary artery wedge pressure is normal, or less than or equal to 15 millimeters of mercury. And the pulmonary vascular resistance is elevated at 3 Woods units. Now, the definition of pulmonary hypertension and chronic lung disease gets a little bit more complex, but essentially gets broken down into 3 groups. Either there's a patient who has chronic lung disease without pulmonary hypertension, that is, they have normal resting pulmonary artery pressures. They have chronic lung disease with pulmonary hypertension, where there may be some mild elevation in pulmonary artery pressures and or an increase in their pulmonary vascular resistance, or patients who have chronic lung disease with severe pulmonary hypertension. Either there's a severe elevation in mean pulmonary artery pressure, or there's an elevation in pulmonary artery pressure with a low cardiac index that may indicate underlying RV dysfunction. Now, there's no official definition of exercise pulmonary hypertension, but I wanted to include this just to help explain some data that I'm going to show later on in this talk. Essentially, what this shows is data plotting mean PA pressure versus cardiac output in patients from rest to peak exercise. This is a multi-point assessment, and each one of these dots may represent a stage. They could be, a minute or 2 minutes apart, depending on how you're measuring these studies. And what it is, it's a plot of how much does the mean PA pressure increase in relation to the cardiac output increase during exercise. Now, patients who fall in a high mean PA pressure to cardiac output ratio tend to have underlying pulmonary vascular dysfunction or an abnormal pulmonary vascular response. Those who have a low mean PA pressure increase for the cardiac output increase usually have normal pulmonary vascular function during exercise. And what's been shown is that the slope of this line, the mean PA pressure to cardiac output ratio, through a linear equation, y equals mx plus b, where m is the slope of the line, the abnormal cutoff is about 3.0 millimeters of mercury per liters per minute. And that usually correlates with people who have exercise pH. Again, there's no official definition, but there's been other data out there by the Lewis group at Mass General that demonstrated that if patients fall into this higher mean PA pressure to cardiac output ratio, they have a higher mortality. The pathophysiology of cystic fibrosis and pulmonary hypertension, what we're going to look at here is the hemodynamic changes that occur over time. Again, most patients with cystic fibrosis may fall into a mild or moderate pulmonary vascular disease, pulmonary artery pressures that are elevated. But in a small group that do progress to severe pulmonary hypertension, they may experience RV dysfunction, where the mean PA pressure increases over time. Pulmonary vascular resistance continues to increase over time, and then cardiac output progresses and eventually drops off as the RV becomes more dysfunctional. And then finally, late in the stage of the disease, right atrial pressure increases. And these changes in hemodynamics are mirrored by changes in the right ventricle. As the right ventricle becomes more dilated, ultimately fails. And these are also mirrored by functional class changes that increase and worsening signs and symptoms. Now, the etiology of pulmonary hypertension in patients with cystic fibrosis is likely multifactorial. This is probably an oversimplification, but at least sort of hints at the potential triggers or causes as to why patients may have pulmonary hypertension. There's some degree of chronic hypoxia, where this leads to arterial vasoconstriction, increased pulmonary vascular resistance. There's parenchymal lung destruction that results in progressive loss of surrounding pulmonary vasculature and increased pulmonary vascular resistance and pressures. In those who progress to RV failure, it's usually due to the work required to produce forward blood flow into the pulmonary circulation to overcome pulmonary vascular resistance. There's other things that may cause or be associated with pulmonary hypertension, such as worsening ventilatory parameters, low partial pressures of oxygen, carbon dioxide, more acidosis, as well as worse spirometry, low FEV1 and FVC. Prevalence of pulmonary hypertension in patients with cystic fibrosis is going to vary. It depends on the age of the patient and the severity of the disease. I selected 3 studies here. It's not all inclusive, but these are 3 studies that have demonstrated pulmonary hypertension by right heart catheterization, mean PA pressure using the old definition of 25 millimeters of mercury. And the prevalence range is anywhere from 26% to 63.2%. Now, using these same studies, we can look at what's the influence of pulmonary hypertension on survival. Each one of these studies looked at either 5 or 4-year mortality, and there really was no worse mortality in patients who had cystic fibrosis and pulmonary hypertension compared to patients who did not have pulmonary hypertension and cystic fibrosis. There was a fairly large and recent systematic review and meta-analysis that was performed in 2018, where a number of studies were looked at from different countries, patients who had cystic fibrosis and a diagnosis of pulmonary hypertension, either by right heart catheterization or echocardiogram, and they looked at whether the diagnosis of PH influenced mortality. Now, before we go into the details of the study, I just want to highlight one of the studies that I thought was well done, this Hayes study in 2014, that looked at the influence of pH on survival. And they did show a positive association in looking at the UNOS database. They looked at patients who had mean pH pressure greater than 25 and demonstrated that patients who had pulmonary hypertension tended to have lower survival probability. And those who had severe pulmonary hypertension with mean PA pressure greater than 35 also had lower survival probability. And this held true for patients who had CF, regardless of univariate and multivariate analysis. And also they tended to have worse outcomes comparatively to patients with other diagnosis of lung disease and pulmonary hypertension, including interstitial lung disease or COPD. Now, this systematic review and meta-analysis also looked at individual studies using this forest plot and determined ultimately, based off of all the data here, there really was not a significant influence on pulmonary hypertension on survival. Now, individual studies, again, have shown that there was some influence on survival, but overall, this meta-analysis didn't really show that. Now, one of the things I was interested in is, the specifics of the hemodynamics. Is there any data out there that may show that specific hemodynamic predictors may identify patients who are at risk for mortality or worsening? In particular, is there anything with the right ventricle that we can identify? And there was one Italian study by Scarsini and others that looked at the pulmonary artery compliance, which is a determinant of RV workload. It's the ability of the pulmonary vessels to dilate during systole and recoil during diastole, and has been proven to be a strong predictor of mortality in pulmonary arterial hypertension. And they identified patients who had a low pulmonary artery compliance tended to have worse survival probability. And this outperformed standard measures of mean PA pressure cutoff of greater than or less than 25 millimeters mercury. Now, I do a lot of exercise hemodynamics. We do supine right heart cath in the cath lab. The data I'm going to present later or next is based off of this supine right heart cath. But we've also started doing these invasive cardiopulmonary exercise tests, which also do a right heart catheterization in addition to ventilatory gas exchange measurements and arterial line placement. I think this provides a lot of robust data. And I can tell you the CF patients that we've done invasive CVET on, their main limitation to exercise seems to be ventilatory, But what I think may be interesting is, could we use exercise hemodynamics to identify something that may determine worsening outcomes, or patients who have worse RV or early RV dysfunction, could we identify them and intervene earlier? So this is our data. Again, it's sort of very small, like other studies, where we had 9 cystic fibrosis patients who underwent supine right heart catheterization. And I compared them to control rest patients who had normal hemodynamics at rest, but came in for shortness of breath for different etiologies. We demonstrate here that patients at rest, right heart cath data, mean PA pressures tend to be worse significantly. So anything that has a p-value associated with it is significant. Without the p-value is not significant. They had worsening vascular resistance, lower cardiac index, and worse pulmonary artery compliance, lower stroke volume. And then when stressed, when undergoing exercise in supine position, patients who had cystic fibrosis, again, had higher pressures compared to controls, worsening vascular resistance, but also some parameters that were also worse too, indicative of maybe worse RV function compared to normals. In particular, looking at the RV end systolic pressure, RV stroke work index, and the pulmonary artery elastance, which is a measure of RV afterload. Now, I split up these groups into those who had cystic fibrosis and no exercise pH, and cystic fibrosis and exercise pH. And really at baseline, there wasn't much difference except for stroke volume. Again, small numbers, but with exercise, we did show that patients who had exercise pH had worse hemodynamics at peak exercise, and they also had worse RV function, RV end systolic pressure, RV stroke work index, and PA elastance. And this kind of correlated with patients who had higher transplant need. So I thought this is at least thought-provoking, hypothesis generating, that maybe we could use exercise hemodynamics to really identify patients who may be at risk for worsening disease. And again, here we identify patients who have baseline pulmonary artery compliance, those who died versus those who are alive. Those who died or were transplanted had lower PA compliance, and they also had a higher mean PA pressure to cardiac output slope, again, indicating that exercise and resting hemodynamics may be beneficial in identifying people who have significant disease. Now, treatment options for patients who have pulmonary hypertension and cystic fibrosis. Now, pH may be a reflection of disease severity. It's unclear if treatment with pH-specific therapies are beneficial. Large trials evaluating pH-specific therapies have not been performed, and the mainstay of treatment is really the prevention of lung disease or disease progression, in addition to the options for lung transplant. In summary, patients who have pH are frequently found in patients who have cystic fibrosis and end-stage lung disease. pH is usually mild, but there can be disproportionate disease. pH likely has a negative impact on survival. Resting and exercise measures of RV and pulmonary vascular function may provide insight into outcomes and exercise capacity in patients with cystic fibrosis. And ultimately, there's no evidence for the use of pH therapies in cystic fibrosis PH at this time. Thank you.